All right, so good morning, everyone. Today's open research office topic is research with community health workers. As a reminder, when you close out the browser after the meeting, you are going to get a survey pop up. It'll be in Zoom. If you guys could just take that, it's really important for our funding resources. And now I'm going to have our speakers introduce themselves and we'll get started.
Great. Thanks, Marshall. Hi, folks. Renee Cadzow. I'm in the School of Public Health and Health Professions here at UB, and then I've been working with the Community Health Worker Network under the umbrella of CoNECT for probably the last 10, 11 years as a trainer, evaluator, and board member for a little while. And I'm going to pass to my colleague, Sam, and then we'll hit Nicolalita.
Good morning, everybody. My name is Sam Radford. I am a community health worker, and I've been with the Community Health Worker Network, since 2011. So like 13 years, almost since its inception. Looking forward to the training today.
And good morning, everybody. My name is Nicolalita Rodriguez de Melgar. I am also a community health worker. I've been with the organization, I think, since about 2016, officially as a trainer since about 2018, 2019. I also work as a trauma therapist, and I'm a licensed social worker. And I will kick it back over to Renee.
Great. I'm going to go ahead and share my slides. Oops. So that's who we are. We just went through your introductions. Can everybody see my screen okay? Great. So we always like to start every meeting with a check-in. So I'll pass it back to my colleague, Sam, to take us through this.
Yeah. And so obviously this work that we do is important, but the people are more important. You know what I'm saying? So we do want to check in on you and see how you're doing today. And so let us know. One is, is not a good day. 5 is going real great, So let's let us know how you're doing 1 to 5, but also let us know, why you came today, why are you here and what is it that you're hoping to get out of this session? And finally, how familiar are you with CHWs of West New York, Community Health Workers of West New York? So if you can kind of, each of you answer those questions, we'll get started with that.
And you can just type those answers into the chat. I'm seeing some 4s, 4.5, 5. That's good. We got a lot of energy for a Wednesday. And anybody's welcome to also come off mute and just share responses to those questions that Sam posed. Or you can type them into the chat.
I can come off mute while everyone else is typing. I am here in person, just having breakfast. So my name's Andrea Carlin. I'm actually a researcher with UBMD Orthopedics and Sports Medicine. But we have a project on community outreach and education for our CPR initiative. So the second question, I'm a little bit familiar with community health workers in West New York from my previous role at Damon University. And today, we're just hoping to get some information so that I can bring it back to my team, to continue our collaborations. Our CPR outreach program collaborates with a lot of members of community organizations. And we actually applied for the Community Health Equity Grant through the UB CTSI. So we're just trying to get some more details on how to bolster that grant application. So thank you for being here today.
Great. And I see we also have a couple of comments learning about CHWs and ways to help connect researchers with the community. Hoping to learn more about working with CHWs and not very familiar, and continuing to grow the network. All right, so we will move right along into our agenda. And so what we've taken you through is a check-in. This is something that we always begin our meetings with to make sure we're grounding in the space and how people are doing and what people want to get out of things. So we'll share a little bit of what we plan to present, but we'll try to tailor it to the needs of the group that's here. So we'd like to explain the roles, skills, and qualities of community health workers. For those of you who are not very familiar, this will be helpful. We're going to explain the importance of co-production and shared power in community-based research. We're going to describe best approaches for research with CHWs, and we'll pull some of this from you all too. We'd like to hear your ideas around this. And then also understanding how to prepare a team for integration of CHW team members. And then finally, we'll close with a checkout and any next steps or questions that folks have at the end. We'd like to invite you to ask questions throughout. I think Marshall is planning to monitor the chat. And also, of course, you can use the hand raise feature as well. I will caution, I'm used to functioning with 2 screens and I have one. So if some of my colleagues can kind of keep an eye out for those questions or raised hands, that would be great. All right, over to you, Nicolalita.
Great, thanks. Yeah, exactly what Renee said. Also, just a heads up, we are used to do our presentation style being a little bit more interactive, and I promise you it's much more fun the more that we participate as well. So just kind of let's get to know kind of who CHWs are and what we do. A lot of the times this can be a little bit nuanced, but it is super important. And so when we're talking about CHWs, I think we can click to the next slide. We're really talking about kind of two bridging the gap between 2 things, right? So bridging the gap between community and then our systems, right? And so the most common systems that we're bridging are really that healthcare and social services systems. And so what I like to explain to people is that community health workers are multilingual, and sometimes actually are multilingual in terms of languages from different countries, but also are multilingual in terms of they speak community language and then also the system kind of lingo. So a community health worker, it not only provides a bridge between community and systems, but also can be that bridge, right? So you might see a community health worker kind of mediating or facilitating. This is somebody who would be able to sit in on interdisciplinary team meetings and then come back into somebody's home and explain to them what just happened, right? And so many times we might see somebody who is in need of care in some way. Maybe they are discharged with medications that they don't understand why it's important to take them, maybe after a surgery, for example, and they just don't take the blood thinner they were prescribed because why do I need aspirin? And so somebody like a community health worker would be able to explain that, that might actually prevent a blood clot. And there's reasons why this is important when our systems may not have the time to sit down with their patients the way that we would hope they would to really explain in that community-oriented language why this might be important or why the system is functioning this way. So I like to kind of use those examples because I think a lot of the times we confuse community health workers with caseworkers. And although we might be able to help in caseworking roles, we're not just a caseworker. I think the next slide.
Oops, sorry.
Great. Yeah. So this slide really kind of points out kind of just the different things that go into making up a community health worker, right? And so on the right side of your screen, you'll see we're talking about really qualities being the foundation of what makes up a community health worker. And one of the core qualities is that person is of and from the community they're serving. They have a trusted relationship with that community that they're serving. And so I think a question that I had for you guys is what would make you trust a community health worker that is telling you or translating for you what the system is telling you, right? Because not just you won't just listen to just anybody that's saying, oh yeah, well, this is why this is important. The doctor is saying that. What do you think makes it, what do you think is the quality there that is key to trusting that person's input in translation? You can come off mute or drop it in the chat. Yeah, using lay terms and being respectful. I'll hold for one more. Experiences in the community and an understanding and knowledge that's being translated. Absolutely, right? So I like to say that, like, if you look towards the left side of the screen, thanks y'all for being participatory, by the way. We're kind of building off of things, right? But we're really building off of that foundation, the qualities of being of and from the community, of having that trusted relationship and having some skin in the game, right? So often I'll tell people that, me being a community health worker and a trauma therapist means I've been on both sides of this couch. I'm consistently on both sides of this couch, right? I have some skin in this game as well. And then from there, we can absolutely talk about the different roles and skills that a community health worker may take on. We can upskill and kind of do a deeper dive into training. And then from there, our hope is to like kind of move into positions where we have both like supervisors, clients, and peers, and just continuing to like build a movement based on this, not just a workforce. Great.
So thank you, Nicolalita. And as Nicolalita shared, the qualities are really foundational. And then on top of those qualities are the CHW core skills and the CHW core roles. And you'll note at the bottom of the screen, there's this C3 link, and you can follow that to see a little bit more about this project. Basically, it was a national project where researchers, CHW researchers all convened to gather data from all of the CHW networks around the country to kind of come to a consensus around what are the core skills of CHWs, what are the core roles. So you'll notice that they're, as Nicolalita indicated, they're more than case management or care coordination. There's really an involvement in advocacy, participating in evaluation and research, providing social support, building capacity. So the idea is not just to provide service to, but to facilitate the empowerment and ability of folks in community to navigate these resources themselves at some point once they build those skills. Anything you'd add there, Nicolalita?
Yeah, just kind of clarifying that, roles are kind of like what we do, and skills are sometimes learned and sometimes are kind of innate. And this is kind of what really makes community health workers very unique, is that we can learn some skills, and other skills are just kind of innate to the person that you are.
Thanks. Over to you, Sam.
Yeah, and so just to give you a little bit of background about who we are, a little bit more background, like Renee said earlier, people were coming together all around the country, actually, to talk about community health workers. And Buffalo had representation there. And so we had a team that went down that ultimately became part of the statewide and national network, the community health worker, and we came back and we created Community Health Worker Network of Buffalo. That ultimately evolved into the community network for engagement, connection, and transformation called CoNECT. But we've been around, since 2010. This is really a network of frontline workers, community organizers, and advocates specifically in areas of healthcare, public health, housing, education, environment, food access, and social services. We work to empower members of the community to define their own challenges and opportunities to take action to self-determine their future. Ultimately, all people in communities have the resources and the power to realize their full potential and health and well-being. And so we work to facilitate that.
So in this spirit, over the years we've partnered. So CHWs, for example, this is a screenshot of a poster we presented at the American Public Health Association. When COVID hit, the Community Health Worker Network established a contract with the Erie County Health Department and assisted with vaccine outreach. Vaccine outreach, though, was done in a way that would be more perhaps responsive to community. So CHWs were staffing those vaccine outreach events. Some of them were outside. They were commingled with lots of fun activities, while also having access to vaccines and vaccine information to help folks who were a little bit more hesitant. And what we found was that those events, because of the presence of CHWs, actually reached more people. There were more people that were vaccinated at those events compared to the Erie County Health Department events that did not have CHWs present. And this is really in the spirit of, this is a symbol from the disabilities movement, but it's been used by a lot of other organizations and movements across the world, is this idea of nothing about us without us is for us. So really co-production is at the core of this. Because this initiative with the vaccine outreach was co-produced with CHWs, it effectively reached community, as opposed to other initiatives that may be sort of top-down focused. Anything you'd add to that, Nicolalita?
Only that, so when we're talking about co-production, we're talking about just that, not just having like the face be there and show up and say why this is so important. So CHWs were involved in kind of every step of that process, not just the delivery of that as well.
Thank you.
And all that actually plays out in the actual paradigm shift that we're hoping to create. Essentially nothing about us without us or for us, actually is the new way. In other words, for so long under the old paradigm, people come in and they create solutions for us and then tell us what the solutions are. And really what this is about is saying that that old way of delivery is not the co-production that Nicolalita just talked about. It's not a partnership. And so we want to have that shift, from the institutional delivery of health to into the institutions partnering with the community about health, from health happening in a clinic or a hospital to health happening, where we live, where we work and go to school, play and shop. And ultimately, instead of people having a perspective some kind of way that the community is sick and in need of a service, really is about, community has ideas and skills and capacities, and we know what we need ultimately to do to be part of what's going to create health for us. And so we work to make that paradigm shift.
So kind of related to this paradigm shift, and as it relates to research and sort of the reason you all are here, we're making this paradigm shift in research as well. Some of this even coming from pressures from the funders. So organizations like the NIH and PCORI have encouraged, strong community partnerships and community co-production even. So what we're moving from is this idea of investigator-driven research where there's less community involvement. And sometimes, and as a researcher myself, I recognize this, that sometimes it's extractive. It's taking information out of community, but not giving it back to community. And what we're working towards is more community-driven research. And there's steps along the way where we might place the research in community or base the research in community. So trying to solve community's problems and including community members in that process, but really moving more and more towards community-based participatory research where the community is full partner in the idea driving, in the research ideas, in the potential interventions, the co-production of these solutions, and addressing issues that are identified by the community. So that's where we're getting into the community-driven research. What issues does community want to solve, and how can researchers participate in that process? So that's really that's where really community health workers are best involved in research, is when it's involving this idea of community-driven research. So towards that end, there's some national resources available for this. We've been partnering as part of the Community Health Worker Network with a national organization called the CHW Center for Research and Evaluation. Their aim is to both build community health worker capacity to lead research and evaluation, as well as develop indicators or measures that match better with community health worker, the workforce and the movement. So how do we measure the impact of community health workers? How do we measure the experience of community health workers in the workforce, and establishing measures to do that, that are co-produced again with community health workers driving those ideas and those changes. What we know from this is the citation for this is at the bottom, and this is one of the linked articles to the CHW CRE, is that from a scoping review, we know that CHWs involved in research help to increase the research team's awareness of the broader community context. So they know what's going on the ground. they contribute to the community acceptability of intervention. So you have an idea for an intervention, a community health worker will be able to tell you, is that going to be accepted or not? Or they might help you tailor it, or they might say, we don't really need an intervention for that. Let's think of something else that's going to address an issue that we know exists. They are there to help assess broader social and or kin networks for participant access, those folks for participant recruitment. So community health workers that have a strong understanding of research will vouch for the researcher and help to link towards people that might be interested or eligible to participate. They negotiate the inclusion of structurally vulnerable communities in research. So they can be that kind of, that gatekeeper that builds the trust with community if they see the research as connecting to community and responsive to community needs. Enhancing participant retention in the study. So understanding that all of the everyday things that might make it difficult for somebody to stay in a study, they'll help to address those things and help with ongoing data collection and follow-up with folks who might experience some of those social determinants that make it difficult to stay on target if it's a particularly rigorous study of some sort. And then they bring community perspectives and voices to the research process and explain or validate the study findings. So if you're puzzled by the results of a survey and you don't know how to interpret it, a community health worker may be able to say, oh, I know why, you're seeing that high rate of response for that issue. This is what's happening on the ground. Anything you'd add to that, Sam or Nicolalita? Anything that rings true? Okay, great, thanks. So I think really what this brings home and that idea that scoping review tells us is that having a community health worker really improves the cultural responsiveness or cultural competence, if we want to use that word, of a research team. So it's going to address that. What often occurs is that cultural blindness where folks are, treating everyone the same, and this ignores the differences, right? It only really meets the needs of dominant groups. Sometimes this is by design in research. There's not a capacity to include different languages, for example. There's certain criteria for which somebody has to be eligible for a study, and there's not a lot of variation with that. But this is kind of pushing us towards making those changes, towards making adjusting the system to be more inclusive and to really meet the needs of our community. So we're really working towards recognizing individual and cultural differences and seeking advice from diverse groups and hiring culturally unbiased staff, as you can see at the top of this continuum of cultural competency. We want to avoid the maintenance of stereotypes or unfair practices when it comes to participation in research.
Yeah, now we want to get some more engagement from you. So based on what you heard, what are the best practices for community engaged work? So if people can just put your answer into the chat or come off of mute and just share, how are CHW researchers different from academic researchers? What are your thoughts? Don't everybody answer at one time.
So we had a large PCORI study, some of you may know, and we had case managers, but in a way this started in 2016 before community health workers, at least to my knowledge, had been developed as well, but using the PCORI way, and I see Mo Yanamagi is on this call. He was one of the people leading this effort at the time. They really tried to engage the whole community in these methadone programs. So what we were studying was telemedicine embedded in these methadone programs, and the case managers really had to engage the entire staff, the leadership, and the patients themselves, obviously, in order to be able to satisfactorily recruit and enroll and ultimately retain people in the study. They also function as a role in engaging patients, and we had a patient advisory committee that would give feedback. And so, although it's not really, it's within the scope of the community health worker, this patient advisory committee or patient point of view became another aspect that was very important, and was also successfully managed by these case managers.
Right, great. Anybody else? Any other thoughts on how CHW researchers are different from academic researchers?
Yeah,
There
hi.
were two. Oh, sorry, Mo.
Sorry, it's just following up on what Dr. Talal was just talking about, because I was on that study, the PCORI study that lasted about 5 years. So it was
7 or 8.
well, yeah, total. But for about 5 years, I guess I ended up going to those clinics, and so what it came down to is boots on the ground type of approach, where you would have to be engaging not only the staff, but like Dr. Talal was saying, the patients in those clinics on a regular basis. So it included a lot of hours just being in the clinic, not only trying to recruit people, but also like as more data became available, you would go and do presentations for both staff to keep them up to date periodically, for example, and also communicate some of that information to the patient advisory committee. So it was really, we were trying to follow the PCORI sort of a new mandate, if you will, when it comes to patient engagement. And because PCORI is also one of those organizations who needed very specific reports on what we were doing. And so it became sort of, you just embed yourself in the community. And I would imagine that what Mr. Radford was talking about, like different from the old school sort of, like academics going and telling people what to do and how things should be, that two-way street where you go in the clinic, you establish relationships, trust, and then you work as a team rather than as an academic, just an academic.
And I'll add 2 more things, one of which I gave a talk this weekend, Mo, at the liver meeting, and in terms of the model and the evidence-based telehealth. And one of the things that came up, which I think is very relevant, is the ability to meet people where they are required that we bring phlebotomy with us and not send people for labs. And so as we're thinking about Hep C elimination worldwide, that ability is really important. And Mo was able to bring with him another staff member who had a 35-year history of experience of drawing blood. And that really, I think, also built trust, because drug users, particularly injection drug users, are phenomenally difficult to get blood from. And so I think that it was Mo perhaps can comment on that specifically, but at least from my vantage point, that was an important aspect to bring with us.
Absolutely. I mean, this is exactly what Dr. Tal was saying, trying to meet the patients where they are, trying to bring the services to them. Of course, you don't want to create the dependency, no pun intended, in this population specifically, but still kind of trying to make it as easy as possible for everybody involved, and then, working as a team.
So it sounds like, having the input from a community health worker helped to develop a process where the research or the resources associated with the research was taken into community, rather than insisting that folks navigate maybe perhaps complex systems that can be intimidating and difficult to get to, recognizing that transportation, income, time, ability to take off of work, things like that could be difficult. So designing one's project, considering those things, can be facilitated by a community health worker.
Yeah, I would say, Renee, maybe we did it by flying by the seat of our pants. But I see, as you and I have discussed on other occasions much more recently, we see the value of this, and I also think that the role of the community health worker has grown substantially in the last 8 years. And so we went in a bit, I would say, and maybe Mo can comment also again, a bit naively, and just sort of, but by listening and by hearing and paying attention and figuring and assuming that we were guests in these methadone programs, we were able to then successfully navigate and so and we've written papers about how we engaged the patients, and we did staff interviews, and and they saw the value of the Hep C. I mean, in a way, we were able to bring indirectly, we were able to, and this is, take advantage of, there's a better word, probably, but the fact that many people have had this disease for a long time, and the treatments had improved tremendously at the time and had just been introduced. So there was a lot of satisfaction. Oh, I have a specialist who I don't even have, who will give me this new treatment that has many fewer side effects. And so it was sort of a package deal. We bring the phlebotomy, we had the advantage. And so, and by being attentive, we were able to, to really have success. I mean, we enrolled 96% of our sample size, which was, and the only reason we didn't enroll was because there weren't any more patients at a few of the sites where we had eliminated this disease. So I think that the community health worker, though, for future work could be very helpful for designing their curricula in a more academic way, let's say. I don't know, Mo, do you?
No, I mean, I basically echo what you just said. It was kind of a lot of the stuff we had to learn the hard way, because we didn't know what to expect exactly. And this is a really difficult population as well. But again, we did have to constantly listen and improve. And like Dr. Tal mentioned, we had the patient advisory committee also, who we had to engage at all times. So it wasn't just listening to staff, and obviously who pull most of the strings, and as far as what we could and couldn't do in those clinics, but also engaging the patients, and down the road developing the trust, not only during the study and by the end of the study, it was pretty high, but then you have fertile grounds for doing any other work there, and word in those communities travels fast. Ask anybody, in that population.
Thanks. So that idea of humility and keeping an open mind and willing to learn and pivot as you go. I see that there's a couple in the chat. It looks like, Ellie, I don't know if you'd want to come off mute and share what you mean about the starting point of the research process being different.
I more so was thinking about like the brainstorming process and who is like at the table when you're starting research and what you're wanting to do as far as like goals, outcomes. And it just kind of impacts who's there, whether it's an academic researcher versus a community health worker researcher. Would you like more?
No, that's good. Thank you.
Okay.
So those were some great answers. Some other examples, on how CHW researchers are different from academic researchers might include, they may not have a college degree, and we should consider that when we do the job descriptions for CHWs. They may not be trained in research. The research should have relevance to their community. They have street credibility. People in the community know who they are, and they understand the community dynamic. They have lived experience within that community. They will have more awareness and access to resources to address the social determinants, so they're better connected in that way. How to work with CHWs. One of the things, I'm gonna let Renee talk a little bit about this. Go ahead, Renee.
Okay, great. And I think that we heard a couple of things related to, recognizing the street credibility of community health workers and kind of exercising humility and being willing to learn. In terms of some other suggestions here, does anybody else want to kind of give some tips before we reveal what's on our list, which is not an exhaustive list? How do you work with community health workers? Any ideas, any tips?
I would say just making sure they're an equal player in team decisions.
Yeah. So recognizing they're a member of the team, a fully integrated member of the team, an equal player. Thanks, Marshall. One tip a researcher on another COG suggested was the way he phrased it, and this is the way that our youth phrase it as well, is go outside. So, spend some time in community in order to understand, the work that community health workers are doing, in order to understand the conditions that exist within areas of our community, the assets that exist, as well as the needs that exist. Connect with one another. So we're all humans, right? So while, a community health worker may not have the same lived experience as you as a researcher, there are some ways that we can connect with each other. So make sure that you create opportunities to do that. Kind of getting at Marcel's comment, establishing mutual respect. Providing training in plain language. And I don't know if anybody else on the call would like to comment on that, if they've used, different ways of explaining things with community partners than they might use when they're talking to their academic colleagues, and how might you do that?
I can share a little bit for like the program that we're currently doing. So we're not working with like an official community health worker, but we partner with the Buffalo Black Nurses Incorporated. So they're one of our huge players in our CPR outreach and education program. So from like a clinical perspective, we work with a lot of providers and like clinicians who are trained in like the full BLS and like CPR, where you need that whole 6-hour certification. And so through our collaboration, and we realized obviously you can't get everyone in the community to sit down and do a whole 6-hour course to be certified. So with that, we worked with our partners to come up with a short, we have 2 versions. There's like a 2-minute verbal training for hands-only CPR, and then we have like a 10-minute practice with the mannequin. So we turned what, we'll be using like medical terminology and things that you would get in a full course as like a clinician into something that can be done really quickly. We go right into the community because we have these partnerships, those gatekeepers that allowed us access into these communities, and they trust us to come in and teach this program to them. So, we have we call it like the no-go thing. So that's something super easy. You can teach it to anyone from a 5-year-old to a 95-year-old. And it's really effective and seems to be working for those groups. So that's sort of how we're not using like a traditional community health worker, but some of our established members have sort of become an unofficial community health worker in their collaboration with us.
And thank you for sharing that. When you say unofficial community health worker, I'm thinking that maybe the characteristics that you're thinking of, they're somebody from the community with those experiences, and they're helping others in the community navigate the process. Is that kind of what you're getting at, Andrea?
Correct. Yeah. Our main collaborator through like their organization, they were already they do different types of trainings within the community. They live within the community, like Niagara Falls region is where our main collaborator works in, but we actually just got a couple new partnerships that are health equity ambassadors through like another program in UB, and then somebody from the Western New York Mobile Outreach. So they're doing like Narcan training, but they want to partner with us to bring the CPR with their existing Narcan training. So yes, they are like truly boots on the ground, going out into the community. And they've asked some of our folks to be a part of that as well.
Great. Maybe we'll have to get them to be official CHWs. We'll fill you in on the next training.
Yeah, that would be great.
And I guess to kind of move along in terms of other strategies of how to work with CHWs, committing to receiving feedback from and co-produce strategies with those CHWs, the folks that you've engaged on your team. So I think we heard that a little bit from Dr. Talal's and Irmo's comments, where, getting that feedback and pivoting is an important way to work with community health workers and community projects, including in troubleshooting. So when there's an issue that comes up, include them as an equal member of the team that can help to troubleshoot the issue. And also really importantly here, because this one is sometimes overlooked, but CHWs, they are a workforce and a movement, and they, they really benefit from opportunities to have CHW specific professional development opportunities. So these can be local opportunities with the Community Health Worker Network of Buffalo, or other ally organizations that do very similar and aligned work. And also nationally with the National Association of Community Health Workers. There's regular webinars and other ways to convene with that organization, and an annual conference called the Unity Conference that's specifically for community health workers. So those opportunities to have that be part of the work that they do is that professional development is really critical. Anything Nicolalita or Sam you would add to some of these, or anybody else on the call?
Yeah, I think just kind of going back to providing training in plain language, this can be something as simple as avoiding acronyms, spelling out acronyms, and limiting the use of jargon. I think a lot of the times we think of how to make like trainings and different things more accessible by kind of dumbing down the quality and content. And in reality, all that we really need to be doing is taking out that jargon and just using plain language.
Thank you. Right. So if in terms of preparing your team to work with CHWs, you want to take the first part of this, Nicolalita, and I'll bring up the end?
Yeah. So when I was looking over this slide, I was also just wanting to kind of clarify that, before we were talking a little bit more on an individual level of how to work with CHWs. Here we're talking about really preparing your team. And so it's kind of a good synopsis of what we've gone over so far. So really understanding, but also having a commitment to cultural responsiveness, cultural competency, and really understanding that that is always ongoing, that you never have arrived at cultural competency. So it's really staying active in that practice and being open to learning, having healthy communication strategies, again, making sure that CHWs are involved in those communication strategies, keeping at the forefront that nothing about us without us is for us. And so in order to have healthy communication, we all need to be part of that. And then also having an awareness of implicit bias. So much of, I think, where we have seen teams really start to falter is when this isn't as, there's not a deep awareness around implicit bias. And again, this is by design. A lot of our systems are set up as such. And so a lot of our community health workers have had to kind of compartmentalize a lot of their identities and experiences going into larger systems. And in order for them to be in a place where they are safe and healthy enough to really build, as a community health worker does, that bridge and really be present, we really want to be doing our work in terms of being aware of like our implicit bias and how that might be showing up in the work as well. Because again, these are folks that are very used to navigating that in the systems, and it is just so much easier if they don't have to. That, and then also back to when we were talking about understanding the qualities, the skills, the roles of CHWs, and that they're not all one and the same, right? So not anybody can be a CHW. There's so many qualities and skills that are innate. If I don't live in the area and I have no idea about this community, there's no real way that I could show up as a community health worker. Could I be an ally? Sure. Could I be an advocate? Okay. But really understanding that, those quality, skills, and roles are very different things that kind of make up a community health worker in whole. And Renee, I'll kick it back over to you.
So I think it's also really helpful to provide your teams with structured, or if they want to self-direct themselves through understanding the CHW workforce and the National CHW organization. So there's a number of resources, both locally with the Community Health Worker Network of Buffalo, but also these great resources at the national level that have been established through consensus with community health workers across the country. So the National Association of Community Health Workers, established in 2019, is really the key convener of CHWs across the US. The National Council of CHW Core Consensus Standards is that body that solicited or elicited feedback from all of the CHW organizations across the country to create these core consensus standards. So knowing that all trainings and job descriptions should reflect these core consensus standards of skills, qualities, and roles for CHWs. The American Public Health Association Community Health Workers section also does some trainings. They have a Educación y Capacitación series, which is all about training and support for community health workers. And that's a quarterly webinar that they'll do on different topics. One of the most recent ones was on supervisors for community health workers. It's really critical, according to that last bullet point there, that the supervision for community health workers is a CHW or somebody particularly with a strong understanding and background of CHWs, but best to be a senior CHW. And then, of course, the CHW Center for Research and Evaluation has a lot of great tools related to the measures, metrics, and how to include CHWs and support CHWs in being part of evaluation and research. And we will hopefully be bringing them into the area for a conference related to CHW research and evaluation in the next year. So keep your eyes tuned for that. All right. So we'd like to give some time for some, a little bit of dialogue at the end here, questions that you might have for us. So I'm going to stop sharing my screen and I'll paste these into the chat. And I'm going to let Sam take over from here.
Yeah. So obviously we want to get better at what we do too. And so let's just talk. Something that you liked or learned today. Anything that you like to learn, feel free to, put it in the chat, or come off of mute and share that way. Something that you would suggest changing or we do different so we can, make this presentation more effective. And what would you like to learn more about? So if you can come off of mute and share your answer or put it into the chat.
We are having an issue with patients being followed up from the Nicolalita Health Emergency Room. So we have a program that allows screening of patients. We identify them for hepatitis C, but given the population that we were discussing with Mo, these patients don't come for their visits, and so routinely. And so one of the ways we've been thinking about is, could this be an area where community health worker patient navigation would be helpful? And I think, from my understanding, are there differences between patient navigation and community health workers? I think that would be helpful in terms of, and how in clinical, we spoke mostly about research today, but in terms of clinical care, how are community health workers involved in delivering community care?
All right, thanks for sharing. Anybody else? Something you liked to learn today?
And I don't know if you want to answer to that question, if Nicolalita, you wanted to navigate that one. We don't hear you.
It would be good to have an answer if that's what you're asking for.
I still don't hear you. That's strange.
You're not muted, but we don't hear you.
Yeah. We can try and come back to.
I'll put in the chat.
Yeah. Yeah. Sorry. But I think that the gist of the question was differences between like community health workers and patient navigators and integration of community health workers in clinical spaces. Is that the gist of it? Okay. So while Nicolalita responds to that in the chat, somebody's welcome to continue asking questions or giving feedback.
I can ask the question. So how would you suggest if our program was trying to reach out to community health workers specifically? We have like these other community collaborators from more established organizations. But I think our group could really benefit from some community health workers, especially when we're doing like pop-ups at like healthcare type events that are already within the community. But how or where we could reach out to some of these folks to try and bring them onto our team.
Do you have ideas on that, Sam, or I can try and approach that one too?
Yeah. Go ahead.
Okay. So really, I think the first step would be kind of defining what your job description is for that person. So is it somebody that you'd like to bring on full-time, part-time? And if it's a full-time position, are you able to provide benefits? Because sometimes it's really difficult for folks who have lived experiences, are navigating many of the social determinants of health, to be able to take a position and not, have some of those supports that come with a full position, right? So those are kind of the logistical first steps. And then in terms of, and then ensuring that job description really aligns with those core skills, values, qualities, and roles. So really reviewing those core consensus standards. And then I would say, share those job descriptions with the local organization, so the Community Health Worker Network, and they can send it out through Facebook and through other mechanisms like that. Or right now we're in the last year of a Health Resources Services Administration, HRSA, Community Health Worker Training Grant. And so there's a team at the Buffalo Urban League who are community health worker coaches, so to speak. They're helping with new community health workers, connect them to employment opportunities or additional training. So if a job description were shared with them, they could see if there's any recent or upcoming community health workers that might have an interest in a position like that. And if it's if you have questions about whether your job description is really meshing with what the roles and skills of a CHW are, you could always send it my way. We can look at it too and give some feedback on it.
Thank you.
Mm-hmm.
All right. Anybody else? Anything stand out from what you learned today?
I wanted to repeat, I think Nicolita's comment about using plain language was such a great one and bears repeating. It's such an important step. I think as researchers, it's, you spend time writing the grant and writing the protocol. And so it's really easy to just copy and paste that language into a consent form and take it all the way to the patient. But really translating that scientific language into everyday plain language is huge. And I think you made an excellent point, and it really does bear repeating about how important that is, that people really understand what's happening. So thank you for making that point. It was well stated.
Great. I think just on that point as well, it really helps to stay in that cultural responsiveness as well, so that it helps us to stay in practice as researchers as well, with just using plain language. Great, I can hear me. I was a little worried that I was speaking into an abyss, but yeah, so it helps us to stay in practice and really understanding our own research, and being able to explain it in plain terms as well. But it also helps us to not be acting within our own biases. So because again, a lot of the times we're like, okay, like this is my professional whatever. And so let me just kind of dumb it down. And again, it doesn't need to be dumbed down. It just needs to be spoken in plain language. And so that can also help keep us along that continuum of culturally responsiveness as well. So thank you.
I don't know if Nicolalita, if you wanted to broach that previous question related to integration of CHWs in clinical teams and kind of the differences between like patient navigation and CHWs too.
Yeah, now that my mic is working.
Yeah.
So yeah, I kind of wrote a little bit in the chat that is specifically to like patient navigators. A lot of the role of a community health worker is really dependent on the relationships they have and they hold, as well as their ability to create those relationships. So when we see things on clinical teams, we have people with a lot of knowledge, a lot of professionalized skill sets that go a long way. And a lot of these can overlap, right? So a lot of the times I talk to people about how, yes, I am both a community health worker and a trauma therapist. And a lot of the times those skills are interchangeable. And a lot of the times they're actually pit up against each other, especially when it comes to like our ethics and how we work, right? So there's things that I would do as a community health worker that I never in a million years was ever trained to do as a trauma therapist, right? So my clinical skill set, in a lot of ways, because it is formed to like serve these systems, doesn't actually work on the ground when building those relationships in a real way, that is going to be leading to effectiveness, in order to kind of bridge those gaps. Does that make sense? Okay.
So in a nutshell, it depends on the particular situation. And I think you said it nicely in the sense that sometimes your skills as a trauma therapist and CHW can completely align, and sometimes they can be completely antagonistic, but it really depends on the situation and I guess it's one of the key differences may be knowledge area in the particular entity, and how well do the community health workers have specific knowledge? That's a question, I guess. I mean, is one of the differences then knowledge area in the specific domain that they're working in?
Yeah, that's a really great point too. So
Okay.
the thing that makes community health workers work and it makes them so nuanced is that the knowledge comes from the lived experience prior to the training, right? So
Okay.
we can upskill, we can train, we can do all of that, but without that lived experience, it's just another professional or paraprofessional. But a community health worker has that lived experience.
Okay.
Okay, so unless anybody else want to share, I'll turn it back over to you, Renee.
All right. Well, thank you so much for your presence today. We're happy to share the slides or any of the resources that we referenced. I can send them to Marshall and she can send them out to folks who registered for the presentation today. We do encourage you to check out the Community Health Worker Network's website, connectwithus.org. And then I also would invite anybody who's really, we've formed an academic advisory group. So if you have an interest in joining an academic advisory group, we're looking to probably convene, at least quarterly, but really to have a group of folks who are working in academia, research, healthcare spaces to kind of join this movement to ensure the integrity of the community health worker definition, roles, skills, qualities is honored in all of the spaces that we encounter in Western New York. We would like to reach outside of that space, but we're going to set our sights on just working locally and helping to connect with those folks at the national level that are doing that work as well. So feel free to email me if you would like to join that academic advisory group, and we'll keep you on our mailing list. I'll put my email into the chat here. And we would love to have additional folks in that space. Thanks, everyone.
Great. Thank you guys for presenting. And once Renee sends me the slides, I'll be sure to send them out to everyone probably tomorrow morning. All right. Have a great day, everyone.
Thank you.